Let's talk about intrapartum management of an intraamniotic infection. Background: 5% of term deliveries are complicated by intraamniotic infections. Intraamniotic infection is associated with acute neonatal morbidity, such as neonatal pneumonia, meningitis, sepsis, and death. Higher risk of cerebral palsy, exposure to chorioamnionitis, 2 times the risk. Even though the relative risk is very low, 2 out of 1,000 live births. So it increased 2 times, so it's 4 out of 1,000 live births. Maternal morbidities, postpartum uterine acne, endometritis, periodontitis, sepsis, adult respiratory distress syndrome, risk factors, low parity, multiple digital exams, IUPC, meconium, GBS, and sexually transmitted diseases, prolonged rupture of membrane. How do you diagnose intraamniotic infection? It's usually separated into 3 categories. Number 1 is isolated maternal fever with single oral temperature of 39 degrees Celsius or 38 to 38.9 that persists after 30 minutes. There could be transient lower temperature elevation that's due to non-infectious factors such as dehydration or epidural or even Cytotec. Second category is suspected intraamniotic infections. First, you will have a fever plus one of the three. Number 1 will be fetal heart tone greater than 160 for greater than or equal to 10 minutes. Number 2 is maternal white blood count greater than 15,000. Number 3 will be purulent appearing fluid from the cervical os. Confirmed intraamniotic infection, positive amniotic fluid test on gram stain or glucose level or culture results. Management of suspected or confirmed intraamniotic infections will be, we'll talk about that in a bit. So management of isolated maternal fevers, one-time fever of 38 to 38.9 Celsius. Isolated fever should still be treated with isolated fever should still be treated unless a source other than intraamniotic infection is identified and documented. Post-delivery recommendations: antibiotics should not be continued automatically, but based on other risk factors, such as if the patient had bacteremia, persistent fever in postpartum. Table 1 is the regimen. We'll talk about this at the end. And then what else? Neonatal implications. First sensitivity infection, yes. Oh, this is afterwards. So if you had a intraamniotic infection, the neonates do not have to be on antibiotics, but there should be enhanced clinical surveillance for signs of developing infection and treatment. A low threshold for treatment. Alright, so table 1 for regimen of treatment. So the recommended antibiotics is Ampagent. Dose 2 gram IV every 6 hours for ampicillin. Gentamicin, I like to use the 5 gram per kg IV every 24 hours. If the patient has mild penicillin allergy, cefazolin 2 gram IV every 8 hours plus gentamicin 5 gram kg IV every 24 hours. I think gentamicin is 4 gram negatives. And then if you have severe penicillin allergy, you can do Clinda 900 IV every 8 hours or vancomycin 1 gram IV every 12 hours plus gentamicin again. After C-section, there should be 1 additional dose of chosen regimen plus the clindamycin IV for at least 1 additional dose. Other alternative regimens, ampicillin sulbactam, which is Unison, 3 gram IV Q6, or piperacillin tazobactam, which is Zosyn, 3.375 IV, 3.375 gram IV every 6 hours, or 4.5 gram IV every 8 hours. Oh, this one's easier to remember. 4.5 gram IV every 8 hours. Ceftazidime 2 gram IV every 12. Cefoxitin 2 gram IV every 8. Erlopenem 1 gram IV every 24.